So thanks everyone, and thanks to the organizing committee to allow us to report from Trench 1, as Adira says. So we're in the trenches working in the Kidney Care Clinic Committee, and this is really a compilation of what we've done and what we're planning to do. So I just wanted to start out by talking a little bit about who we serve. So we serve over 11,000 patients in 14 kidney care clinics. These range in size from a 300 patient clinic in Penticton to a 1,500 patient clinic in Fraser Health. And you'll see that in Abbotsford, and you'll see that Fraser Health has now surpassed 3,500 patients registered in their kidney care clinics. I didn't know about the fancy app, so I'll do this very quickly. So I have a little bit of test your KCC knowledge to give you a few pearls that we've learned along the way. So Children's Hospital's average age for their KCC clinics is 10 years of age. Which health authority do you think has the youngest patients? Most people would say not mine if you've been in clinic, right? And it's actually mine. So Vancouver Coastal Health, the average age of KCC patients is 71 across the board in BC every year. You know when you get the report it's going to be 71. Vancouver Coastal Health actually has an average age of 67. And the oldest is not on the island where people are supposed to go to retire. It's actually Fraser Health. So Fraser has an average age of 73. Most patients with CKD, more patients are male than female. And so 55% of all the patients we care for in the province are male. And in children's, about 65% are male, mainly because of some of the diseases that males get earlier. Which adult KCC do you think has the most female patients? So interestingly, Northern Health actually has more female patients than male patients. And whenever you see reporting out of CKD parameters, it's never more females than males. So there's 52% that are female in Northern Health, and Vancouver Coastal only has 40% female. Who has had the most growth over the last 10 years? I'm sure this is not a surprise to those that live work in Fraser, and I've heard a little roar. Fraser Health in their kidney clinics has had, over the last decade, almost 100% increase in their registered patients. Some patients with CKD are registered but followed in offices around the province, and some are followed in the KCC model. The highest percentage of CKD patients followed in a clinic model will be a tie between Interior and Children's, where basically virtually all of patients, once they're registered as a CKD patient, are followed in the clinic model. 99.2%, I think, at Children's, so probably just data. And this is embargoed. This is a report that will come out next week. Most preemptive transplants in the last 6-month report that went up to just this fall. So which of your health authorities actually did the best? Was it the one with the most patients? Was it someone else? Actually, we really want to congratulate both VIHA and Interior health authorities that aren't the biggest and are farther away from the transplant center. And both of them had actually 4 preemptive transplants coming from their health authority in the last 6 months. You'll see that report soon, and that's more than double what they've ever had before. So that's pretty amazing. So our committee was established in 2011, and really I think what we've aimed to do is provide some priority setting with respect to CKD care and programming, develop standards, guidelines, tools, teaching resources, but not just for the sake of creating them, for the sake of actually making something better. One of the, I think, most important thing we've done is establish important quality indicators and monitor them, and then go back and do local QI cycles if we're not meeting those targets. And we're here to support local implementation of provincial strategies and initiatives. The local feel and look and flavor of the initiative will be a bit different in each place. That's how it should be, but why we're doing it and the vision needs to be consistent, and that's what we're for. We do link closely with other programs that you'll hear about, such as Transplant, Hemo, PD, home therapies, vascular access, and conservative care. And since we're kind of at that kind of link between GP and others, we really try to follow the tenets of chronic disease management, shared care plans with GPs, advanced care planning, and palliative care. As Adira mentioned, we have lots of interested people, and we have reps from all health authorities, all disciplines. We have had wonderful engaged patient partners. We actually are at a time where we're looking for more, so if any of you have an interested patient, let me know. But these are the people that are involved in our committee. We've been asked to tell you kind of how do we organize ourselves, how do we get things done, and this is just the one slide of what we do. So it's about every 2-month commitment for members of the team. We do meet face-to-face most years, once a year. We usually have about, and this is done on people's lunch hour, we usually have about 25 people or more on the call every time giving input, and we've developed a kind of a finessed way to make sure everyone has input and we actually do things in a 1-hour period over a lunch. As Adira mentioned, I'm transitioning from this role, and I'm thrilled that there is a successor, Dr. Mike Bevilacqua, that has agreed to take on this role. I'm very excited because the program will be in good hands. Janet Williams and Alexis Watley provide amazing administrative and project management support. And importantly, if you don't want to sign on to the committee forever, we try to do most of our projects as time-limited, specific, topic-specific projects that have an end. So you don't just sign on and you're a lifer on a committee until you change roles, which seems to happen sometimes. Adira mentioned a lot about first in kind, and I wanted to briefly mention that the best practices in kidney care clinics took a few years. It's not new, but it definitely was a first of its kind. When we did a lit search to try to figure out how to create our document, there was nothing there. And we've just updated it. It's very similar to the original with maybe the new nuances of healthcare 4 or 5 years later. But other programs and provinces you'll see are now developing very similar documents, all with credit to BC. A slide to talk about some of the completed activities for those of you with less than 2 years in renal might not know about yet. So in kidney clinics in BC, we have a standard way of ordering, reviewing, and following up lab work, including what to order, how frequent, and what we're going to do with the results. We have a comprehensive conservative care pathway. We have these depression and anxiety guidelines, including what we do and what the family practitioner does, and I'm very glad to see the 35,000 hits. And we do have these symptom assessment and management protocols, and we also have been able to secure funding for the medications that the symptom protocols recommend in people with a GFR less than 15, which is quite amazing, and people say, how do you do that? And if people believe, it's actually not that much money, and we haven't actually spent that much, but when you do it wisely like this, you can't really use the symptom management protocols if people can't afford the medications. And there are a lot of patient handouts for you to see. We've been asked to briefly go over 3 activities that we want to showcase today, and I have picked out of many of them these 3. So the first is the Quality Indicator Report, and it's not really new. We've been doing it since 2011 every 6 months, but it's been such a driver for change that I don't want anyone that works in kidney clinics to know it's not there. And this is just a screenshot of what it looks like. It is not to read it, it's to know that it is not blinded. It is done by each clinic. It is not just done by the health authority. And with appropriate privacy and guidelines, we will pull patient-level data for you, so if there's a particular metric that things aren't going too well, we can have individual programs do local QI for their program. And this is where Adira laments that there's about 6 bullets, and all of them could be publications. They're amazing advances. So from when we started initiatives to try to move these needles to the last report in 2018, we've increased the number of patients starting on an independent modality, and this is not including transplant. This is just home hemo and PD from 29% to 40%. We knew that not all our patients choosing PD started on PD, and we've increased that from 66 to 75%. And sometimes the people not starting on PD, it's just because of reporting, because they actually got their preemptive transplant, but PD was down for their dialysis decision. Some are things we have to work on. We've been able to save the healthcare system by increasing the hemo starts as outpatients, and this really wasn't an initiative. This was sitting down, looking at the data, seeing that different health authorities did things differently, and asking questions. Well, why are you starting patients in hospital? We've increased the hemo starts with a mature fistula. We've increased the patients in our clinic with low eGFRs and a preemptive fistula. And we've started embarking on ESAS for those with a GFR less than 15. And I wanted to show you, these might be hard to read, but these changes take time. So this is by every 6 months. And the first one on the top, your top left, is chose PD and started PD. And every 6 months, this is provincial, it gets a little bit better and a little bit better and a little bit better, because you need time, you need the patients to actually then go on the modality, and you need time to spread the change. The GFRs of less than 15 and assessed for symptoms with ESAS, we had one clinic doing it, no one else doing it, and then slowly people would say, oh, it's not that hard, give it a try, and then now we have most clinics on board starting. And this is not a metric, the percentage of patients choosing conservative care, which is about 25% of people with a GFR less than 15 are on a conservative care pathway. This is not a metric because you want the right choice for the right patient. You don't want to deter someone from doing a dialytic modality if that's the right choice for them. But in our clinics today, the same amount of people are managed and die on a conservative care pathway as start hemodialysis, not start all dialysis. So it kind of changes the model of us as prep, right? As prep for dialysis, and just as much we're providing supportive care to these patients. Transplant First has been discussed, but this truly was a renal agency and BCT partnership. We were very fortunate to have some dedicated time to really try to look and say, how do we increase the number of preemptive transplants coming out of the KCC? We've changed the modality education a bit to reflect this, and I'm going to show you that. We've developed the resources that we think needed to be developed after talking to you. With help with the BC Kidney Foundation, the living donor volunteers have been added to the Kidney Connect peer support program. We've been able to update Promise so you can document in your KCCs those donor outreach conversations if you've approached people about living donation. And we are, with the help of BCT as well, actually making indicators that some will come from BCT data and some will come from renal agency data that says, what are we doing in our kidney clinics? How many people are we approaching? How many people are eligible for that education? How many people have identified they have a donor? How many people actually have a donor? And that information isn't available anywhere else because most of the data for transplant starts on the side once they reach the transplant program. The website has a lot of this information, and we've linked it back and forth between the BC Transplant website and the BC Renal Agency website, so you can go to either. And I wanted to spend a few minutes talking about the modality education. So when we started this years ago, everyone had like a PowerPoint on their desk with clip art that was doing education kind of their own way, and so we took a long time trying to standardize modality education. And then we went back to patients and we said, this is what we thought we taught you, what did we teach you? And then we went to providers and said, how was that? And we got some feedback. And so we've just done a refresh to our modality education. And there's two parts of that refresh. First, we've tried to uncouple modality education being, I'm going to teach you today about transplant, hemo, PD, and conservative care, to taking a step back and those patients with a higher GFR, but you think they're going to progress, asking them to be educated with respect to transplantation. So they can sit and just hear about transplantation and why it's important. And then if you either get people late or just haven't got to that stage, there is the full all modalities education with transplant there as a refresh. We are working now on making sure these are all online and that they're translated into all the languages you would deem appropriate. And the first one there on the left is the transplant education, and we've worked really hard to keep it as simple as possible. We've had a lot of patients look at this and go through it. You know, honestly, we've still had a bit of problems because your kidney clinics are so busy. So to actually implement this change and change the mindset to put another step of modality education, it's not easy. It's not easy in my own clinic. So I urge the managers and the CNLs to kind of try to work with your program to figure out how we can do this. Can we take away one clinic visit and do that education? It's really so important. And then the all modalities education, that's a screenshot of it. Many people have now used it outside of the province or tweaked it, and really it's promoting the appropriate kind of grade of care that we would like for patients. These are available in flip charts supported by the Renal Agency. They're available as PowerPoint. They're available online on the website. They're available with voiceovers in different languages, or soon will be the new one. So what's next? Well, Mike has to clean his inbox because he's going to be getting it. I'm excited about what's next. I think we still have some work to do on the Transplant First initiative to kind of really embrace our kidney care clinics as the best pre-transplant clinics we can be, and that's going to require some further work. We are, under Mike's direction, starting the polycystic kidney disease best practices document as an arm of the KCC best practice. So you will likely see some PCKD patients that you might have not seen in the clinic model to receive that standardized appropriate care. And if you haven't been approached for a working group but are interested, feel free to let me know. We are working with the Integrated Palliative Care Initiative to look at the information we're providing patients with the conservative care pathway and ensuring it meets their needs, and using that valuable information that the Renal Agency has with the Palliative Care Committee. And every 3 years, we really strive to update our guidelines, our handouts, our papers, and Janet really keeps us on task for that, saying, okay, there's another one we have to update, and I think that keeps it fresh and not just a document that stays on a website. So I think that's my last slide. I'd just like to take this opportunity to thank all of you in the room that are on the KCC committee, and it's really been one of the most rewarding parts of my career, and I look forward to being on the phone as a member. Thank you.